developmental glaucoma is nothing but a spectrum of clinical condition which is associated with rising intraocular pressure in its early years of childhood, between birth to 5th year of age. There are so many terminology has been there in the literature. It's congenital glaucoma is synonymous with developmental glaucoma, and of course primary congenital glaucoma is nothing other than our routine, our primary infantile glaucoma, or what you call it generally as the ophthalmos, and also it's otherwise called as infantile glaucoma. And juvenile glaucoma is a non-specific term referring to any type of glaucoma occurring later in childhood after the 5 years of age and through the 3rd to 4th degree. It's not uncommon in our country. We used to see a lot of this type of juvenile open angle glaucoma is this thing. And of course, primary congenital glaucoma is an isolated angle anomaly which we used to see in a lot of cases when compared to other developmental glaucomas. And this, depending upon the age of onset, it can be neonatal, infantile, or late onset glaucomas. And of course, juvenile glaucoma is very, very late. There is no ocular enlargement and no congenital anomalies and with open angles. And this developmental glaucoma, apart from our primary congenital glaucoma, there are so many other types of glaucoma which may be associated with systemic and ocular anomalies. There are certain glaucomas which is associated with ocular anomalies are our anti-chamber cleavage syndrome. There is accent-filled Riget's and Peters and other aniridia and etc. There are some other conditions which will be associated with the systemic problems like Marfan's, wheel Marcassani and trisomy and all these things. They will phacomatoses. We used to see some of the cases, especially with the Strasbourg syndrome, secondary glaucoma, something like that. Then other glaucomas due to the congenital, after congenital cataract surgery, which is nowadays is very, very uncommon, but previously we used to see lot of glaucomas. Close to 80%, 60 to 80% of the cases they have developed glaucoma long back. But now the incidence of the new finer surgical technique, the glaucoma following cataract surgery in infant is very much reduced nowadays. Then of course traumatic and uveitic and other things, especially steroid induced, we are seeing a lot of cases even now. This is nothing but child with polychoria, iris atrophy and typical dental anomalies. Suppose if this is, we have to look for this peg-shaped teeth and microdontia. It's a typical of Axenfeld Rieger syndrome. And most of the patients, about more than 70% of the patients, they will be associated with glaucoma. So in that case, depending upon that, usually this surgical management is best option when compared to medical, and we have to be very careful in using the antimetabolite in this case because already the endothelium will be compromised. Then of course the Peters anomaly, where we will have a central corneal opacity and with anterior polar cataract sometimes, and usually it will be central. Always it's bilateral, but it's very difficult to treat. In some of the cases we have done a PKP also, which will do better in this thing. Then of course aniridia again is one of the important developmental glaucoma in children, and this is not all cases of aniridia are associated with glaucoma. Here again it's about only 50% of the cases are associated with glaucoma. And there are 3 types, and I am not going to detail, and of course you have to look for the Wilms tumor. And here the 2 things are very important. One is the cornea, especially the corneal peripheral metabolites of the corneal epithelium, so peripheral pannus and corneal complications are very high. And second one is the macular hyperplasia, that's why the visual acuity will be very, very less. Then of course Marfan's, all the systemic and ocular features, glaucoma is very, very difficult to treat, and of course this is microspheraphakia, wheel Marcassani, exactly opposite to that of Marfan syndrome. Here again this glaucoma is very, very, because of the spherophakic lens, the lens will, it can block the pupil or it can come to antechamber causing glaucoma. So depending upon the situation we have to act. Then of course the phacomatoses, suppose if it is involves the tip of the, that's the ophthalmic division of the third especially nerve is involved, then the chance of glaucoma is very, very high, especially mainly because of the rise in episcleral venous pressure. If suppose it occurs in the first 3 years of age, the child will have what is called the secondary ophthalmos. They will have enlarged cornea with this dilated tortuous congenital vessels, and eye will be so red and very red. So in this case, its medical management is little will not help to do so surgical management, but it's very, very risky. So we have to take all the precautionary measures to control the intraocular pressure, and also especially during surgery. One thing is bleeding, and another thing is the thick tenons, which leads to failure. So we have to take care of all these things with antimetabolite and everything. And we used to do a prophylactic sclerostomy in all these cases, so that you can avoid intraoperative and postoperative suprachoroidal hemorrhages. Then of course traumatic is not uncommon in children. It can so many causes for traumatic glaucoma. And coming to the common condition is the primary congenital glaucoma ophthalmos. The prevalence is not that common, it's 1 in 10,000 births. Mostly it is sporadic. It's more than 80% of the children are no family history of glaucoma, non-hereditary. Only 10% are autosomal recessive. It's more common in males, 3:2. And of course, presentation 25% of the cases, the children born with glaucoma, and 60% by 6 months of age, and 80% by the 1 year. And usually it is bilateral. 70 to 80% are bilateral, but you used to see about 20% of them unilateral glaucomas. Genetics, of course, so many studies have been done, and also most of them are sporadic. This is a locus in the inherited pattern, and the gene involved in different types of developmental glaucomas. And below the 3 years of age, the eye is more elastic, that's why you have ophthalmos. After 3 years of age, there is a toughening of the cornea and anterior sclera. So posterior sclera is elastic. So if the child develops glaucoma after 3 years of age, there is a anteroposterior elongation of the globe. They will have an axial myopia rather than ophthalmic eye. And management is a challenging problem, definitely. It's even adult glaucoma, still we find it very difficult in some of the situations, but in children it's very, very challenging, and we have so many options, medical, laser and surgery, but surgery is the key, the surgery option for the managing this condition. But it's not that easy, because in children we have so many drawbacks like poor cooperation and frequent examination and anesthesia, and difficulty in assessing the visual function, and also they have to come for lifelong follow-up and all these things. So examination and anesthesia is one thing we used to do frequently in all cases of congenital glaucoma up to the age of 4 to 5 years, depending upon the cooperation of the child. And all these, especially if we do surgery, we used to do 3 months after surgery, then 6 months, then 1 year, something like that. We used to have a system. And during every year, you have to do a corneal assessment, and also the refraction, tonometry, and slit-lamp exam. This detailed examination of the anterior segment, gonioscopy, fundus, and corneal thickness, of course, it's in all these cases. And these are the effect of, because since we are dealing with so many anesthetic agents, we must better to know about the various the action of the various anesthetic agent on the intraocular pressure. Previously, we used to use ketamine. Ketamine is the early stage of induction, not to produce much of alteration in the intraocular pressure. But nowadays, midazolam is the one drug which is very commonly used, intramuscular, usually intravenous we used to use, and usually it will not alter the intraocular pressure in its early stage of it. So immediately after injection, we have to do the intraocular pressure evaluation. Generally, we have to go for the other examination. Then of course, tonometry and all these things. And the management, as I mentioned, mainly surgical, and there are so many surgical options are available to manage the developmental glaucomas. One is goniotomy. Goniotomy is a very good preferred technique to in cases with the primary congenital glaucoma. But one of the disadvantages of goniotomy is you have to have a clear cornea to do goniotomy, and the second thing is when you use a direct gonio lens, especially the Barkan lens, when you press over the eye to visualize the antechamber angle, you can have a distortion of the globe. So in that case, it's very, very difficult to do the exact cleavage of the trabecular meshwork, that's Barkan's membrane. So many people now switch over to the alternative thing, which is a trabeculotomy, which has got so many advantages. It can be done for any type of, even the totally corneas opaque we can do, and also even failed cases of goniotomy we can do, and it can be combined with the trabeculectomy in advanced cases of congenital glaucomas. The other procedures are not that important, but in advanced cases, repeat suppose 2 or 3 surgeries failed, then we will do the CTANs, that's especially the AGV or RD implant, and ultimately finally we will go for cyclocryotherapy. And of course the combined is now is giving very good result when compared to simple trabeculotomy itself, because it works in 2 ways. It bypasses the trabecular meshwork and also the bypasses the Slem's canal, so that it will have a very good control of the intraocular pressure. This is a case of a congenital glaucoma, about 2.5 years old child with very harsh hazy cornea, 14 millimeter diameter, and here we have to take a very careful dissection of the scleral flap, because sclera will be already thin, so we have to be very careful. It should not be too thick or too thin, and then you extend the incision of the scleral flap up to the limbus, 0.5 millimeter anterior. Then identification of the Slem's canal is one of the important steps. Unless you know the surface anatomy of the Slem's canal, is very, very difficult. Usually it is present just the junction, just behind the junction of the anterior grey zone and the posterior white zone. So you have to do a multiple scratch incision, and at one point of time you will be seeing a white glistening band which runs circumferentially around the limbus. That's the outer wall of the Slem's canal. So you have to make a small nick in that glistening band, so that you can enter the lumen of the Slem's canal, and then you have to pass the trabeculotome. Hence trabeculotome, the right and left is available. Gently you have to introduce into the Slem's canal, because if you use it forcibly, you may enter a false passage, or you will go behind the iris and you injure the lens and zone, so that you will have other problems. So you gently should not use force, so that you can avoid all these complications. Then of course after doing the trabeculotomy, you can do a trabeculectomy combined. We used to do combined in almost 90% of the cases. And then for doing trabeculectomy, you have to enter either anteriorly over the base of the scleral bed, or you can undrop the Slem's canal. You can undrop the Slem's canal on either side, and you just go anteriorly and remove a block of tissue, so that you can have a very good trabeculectomy ostium. And then you do a PI. When you do a PI, you should be very, very careful, and also we have to tell the anesthetist we want to have a controlled anesthesia, because suppose even if the small eye is little bit tense, then you will have a lot of problems. Even if you do a PA, you will have a vitreous disturbance. So eye should be very, very soft when you do enter the anterior chamber. So then it's very, very difficult to manage the vitreous. So you have to have a very good anesthetist for this type of cases. This you do it with Kelly sponge or with the whatever technique I told you before. After my then suturing is again it's a thing. Suture you have to put multiple. It should not be too loose or too tight, because that's what we used to say, and it will not leak. Should not leak, because in children it's very, very difficult to manage the post-operative complications when compared to adults. So you must have a very good firm suture to oppose the scleral flap to the scleral bed. Then of course the conjunctiva is sutured with 80 vicryl in a watertight manner. And then of course subconjunctival Decaton and garamycin, and then post-operative management of course is very, very important. We used to give steroids and heavy dose in the early stage, and in a tapering manner with cycloplegics for about 6 to 8 weeks. So trabeculotomy with trabeculectomy. And of course the one part is there's a control of the intraocular pressure is one part. The other part is the visual recapability. Most of the time you will forget, because most of the cases they will have a myopic refractive error, and the astigmatism is very common, about 30% of the people. Anisometropy again is common because of the unilaterality. 20% of the cases will have anisometropy. So all these conditions we have to take care of so that we can visually rehabilitate. And also the visual outcome definitely depends upon the early diagnosis and prompt institution of the therapy, and we have to educate the family, we have to counsel the family, because otherwise it's very, very difficult to have a successful treatment for this type of glaucoma. Thank you very much.